Swanson, and I'm the volunteer coordinator for the Methodist Hospice program. Jan Davidson is one of the nurses for the hospice program. I've been there 20 years and Jan's been there about 25 years. But the purpose of our discussion today, and we hope you get all your questions answered, and if we don't know the answer, we can certainly work on finding out for you. But our discussion is going to be around the topic of what is palliative care and what is hospice care. So we're going to go into that a little bit and hopefully get some questions answered and give you some information. I'd like to just start out by saying, how many people are familiar with the term palliative care and know what it means? Okay. How about hospice care? Yeah, that's what Jan and I know better too. So, well, good. That's a good starting point. So, we're going to start out by Jan's going to talk about some of the similarities between the two programs, and we'll be referring to the handout that you have. So you do have this written information as well, and we'll be happy to stay afterwards to answer any questions that you might have too. So again, thank you for having us, Brian. We're happy to be here.
As you can see from the handout, the first set of 1 to 4 is, as Libby said, the similarities between palliative care and hospice care. So number 1, we both focus on comfort and good symptom control. That's always at the primary part of what we suggest for care, what tests may be appropriate, what medications are appropriate, is all focused on what is making somebody's life the best possible that it can be, and also with as much comfort and symptom management as we can provide. Good morning. Good morning. Good morning. Welcome. We have some handouts, and I'll give these. Here. Those are for you. The second point on your outline is about how is palliative care given, or as well as hospice care, and both are given by a team. So it's doctors, nurses, social workers. It's a team approach, and that is being a hospice nurse. I know that I could have never done this work as long as I have if I hadn't been part of a team. It's a wonderful feeling to know that you've got excellent backup system from social workers who know about insurance, and I don't know about insurance, and so that is an important similarity between palliative and hospice care. We also encourage people to do advanced planning, number 3, and advanced planning could be a healthcare directive, which used to be called a living will. How many of you, by the way, have a living will? Good for you. That's unusual to find an audience of this size that many people have an advanced directive or a living will. So those are important to have people begin to think about. What is it that I want or don't want when it comes to, kind of an ongoing illness, or perhaps, when the illness becomes a terminal condition. Number 4, oftentimes people think that, it's a place that you go to, especially for hospice care. Now, it can be a place, but more important, it's a philosophy of services and care that can be given any place. So that's hospital setting, private home, group homes, wherever. It kind of surprises a lot of people that we give hospice care in nursing homes, but it has worked out so well. There are many nursing homes that give excellent end-of-life care. So we are there to just kind of bolster their excellent care and to give them a helping hand. Hospice also has what we call residential hospices. Now, these are places that people go. And do any of these names sound familiar? North is one. NC Little. Anybody heard of NC Little? It's in Edina. Let's see, what are the other ones? The Pillars?
Yep, the Pillars.
The Pillars is another one. Anyway, those are places where, now that's not palliative care, that's for hospice patients. So any questions about kind of those first 4 points? Okay, now I am going to just kind of give you a case study for someone. Now this is not a hospice patient, this is palliative care. Mrs. Nelson is a 69-year-old woman who lives alone. She has had COPD, which means chronic lung disease, for approximately 12 years. Mrs. Nelson, at this point, still has some good quality of life, although in the last year and a half, she has become dependent on her oxygen. She has a history of several bouts of pneumonia, 3 of which she has had to go to the hospital for, and that's been in the last 2 years. On her last hospitalization, and that was in March of this year, she, with the help of her 2 adult children, decided it was time to seek a palliative care consultation. So the doctor, nurse, and social worker came to see her in the hospital and talked at length with her about what are your goals now. Your quality of life is still pretty okay, but if something sudden should happen, if you have a crisis, what is it that you want help with and what are your goals? And her goals were, she wanted to stay as independent as she possibly could. She had lived alone for several years, and she wanted good control of her symptoms, especially her breathing difficulties. And which I think most of us could attest that those are some pretty practical goals. So the palliative care team kind of set out a plan of care, hoping to keep Mrs. Nelson out of the hospital as best they could, not do unnecessary tests, and to make her quality of life through balancing medications, use of nebulizers, which help lung disease. And so after that hospitalization, she had just a good feeling about, I've been listened to. I have also someone who, is concerned about my comfort, not just a curative mode. And as you're probably well aware of, in today's society, if you want aggressive care, you can get anything and everything if you're willing to go through the tests or the trips to the emergency room. And there's nothing wrong with that. I think it's not a matter of being right or wrong. If people choose to seek aggressive care no matter what, that's fine. But there are oftentimes unnecessary tests and procedures that can be very uncomfortable or can be something that somebody needs to be able to say, is this your choice? So that's kind of the key to looking at it as a team approach, listening very carefully to what somebody wants, treating people as individuals. You're not just a lung disease. You are a person with your own individual wants and needs.
I think that it's important to point out, as Jan said, I think one of the good things about palliative care and hospice care is open conversation. If you're in palliative care and you're part of this team, then your goals are known. And sometimes people say, you know what, more than anything, I want to stay out of the hospital. They're not doing anything for me there, or what they're doing, I don't want any longer. So as long as the conversation is being had, it gives you an opportunity, or anyone an opportunity, to be able to look at what they want and make sure what they want is happening. And you're just not on a kind of a treadmill of this is my diagnosis, so this is what happens. I get an infection, I go to the hospital, I'm hospitalized, I get antibiotics, I go back home, it starts all over again. And maybe if you had the conversation, you would make a different choice. So I think it's all about option and conversation. The patient that I'm going to talk about is a hospice patient, not a palliative care patient. And this is a 60-year-old man. This is based on some of the patients that we serve, who was given a diagnosis of pancreatic cancer, which is a terminal diagnosis. It's unfortunately not something that one recovers from. And at the beginning of his diagnosis, they asked him about, what are your goals of care? And his goal was, I don't want any unnecessary, I'm really concerned about pain. I want to have as good a function as I can, and I don't want to be a burden to my family. And that's one of the comments that we hear a lot is, I don't want my family to be burdened with my care. I don't want unnecessary things happening, and that's very important to me. So this patient did start some treatment, but it was palliative in nature because none of it was going to cure his illness. But he did have some radiation for comfort. There are some, and this is a mistaken thought I think sometimes, there are some treatments you can have even if you are a hospice patient, even if you do have a terminal diagnosis. In hospice, it's the diagnosis is a prognosis of 6 months or less to live, certified by a physician. So this patient, even though he had a terminal diagnosis, he was getting some radiation for comfort, no chemotherapy. There wasn't any that he could have, but he was going to have some radiation, and came into the hospice program with the goal of staying out of the hospital, not being a burden to his family, and having his symptoms well controlled. So then the hospice team works hard at making that happen and helping his family care for him. And you can receive hospice care wherever you are. You can live here, you can live in your own home, a nursing home, assisted living, a residential hospice, as Jan mentioned. So wherever someone is, you can receive hospice care. So this man did receive hospice care. The nurse visited him at home, kind of became the eyes and ears of the doctor, so he didn't have to go to the physician any longer. And he was able to stay home until the end of his life with the support of the hospice team and his family. And he lived for about 6 weeks in the hospice program. The average length of stay in hospice is about 60 days, and that's the national average. So even though one has a prognosis of 6 months or less to live, you can see that it's often much shorter than that. For a variety of reasons. Sometimes people just aren't ready to choose it. Sometimes their physician or their care team doesn't start that conversation early enough. And so those are some of the reasons why people maybe get in a little late in the program. And the other thing and this is listed in the differences too, but you can opt out of hospice and you can opt out of palliative care too. You could start treatment or join a hospice program and then decide that you wanted to be more aggressive with what you had, with whatever illness you had. And then you just you sign a paper and you make a different decision. So hospice is for terminally ill people who maybe have had a chronic illness, but they're at a point now where it looks like they have a limited life expectancy.
Any questions about that? Again, referring to your outline there, and Libby took care of the part about limited life expectancy versus in palliative care. Treatment can literally go on for months or years. We actually asked one of our palliative care doctors at Park Nicollet, and we said, well, as far as you can remember, what is the longest time that you've had a patient on palliative care, and he had to think for a while, but he said, I think it was about 5 years. So you don't see that obviously in hospice care, but palliative care is for anyone with a serious or chronic illness. And again, a lot of these terms can be pretty, there's definitely a gray area. So it's not totally black and white. We have also had some people that have been cared for years in a palliative treatment program and then eventually become a hospice patient, but not always. Some people they just stay in palliative care. Again, talking about palliative care, it allows much more aggressive treatments. There are CT scans, there are MRIs, things like that, that would not be probably appropriate for a hospice patient because it's unnecessary testing, and that's one of the reasons that the government likes hospice care, is because it's very cost effective. The other part is that in a palliative situation, a person can be, like what we call a full code. Does anybody know what that entails? A full code? It would be like when you call 911. That is, if your heart stops, the paramedics try to restart it. If your breathing stops, they could put you on a respirator. It is truly life-sustaining treatment. On the other hand, in hospice care, and this can be a stumbling block sometimes for people, we say, do not call 911, call us 24 hours a day. I know it kind of goes against what we're all taught to do. 911 is the way to go. But most of our hospice patients don't want that aggressive intervention. They don't want to be put on a respirator. Or they don't want somebody to come and pound on their chests and try to get their heart started again. So a key difference in palliative versus hospice. The other thing, and this happens most of the time because of just what I spoke about, that we designate our patients, and it's a patient's choice, as what's called DNR, DNI, and that's right on your outline there. And that means do not resuscitate or be put on a breathing machine, and do not intubate. Kind of one is like chest compressions, that's actually the DNR. DNI is don't put me on a breathing machine. Is that clear? So key differences. Now, because of legality, we can accept someone into our hospice program even though they're a full code. And the only thing is, if then they do call 911, they automatically have made a choice for much more aggressive treatment, which is fine. Just like Libby said, people can get in, go out, and come back in if they choose to. We had one gentleman, he was 93, and he had a chronic lung condition, and he entered our program and seemed like he was very okay with not doing anything aggressive. Well, he got pneumonia, and now we give antibiotics in hospice care, but we don't do intravenous antibiotics like they do in a hospital setting. Well, he said, I don't think I'm quite ready for this. So he opted out of the hospice program, went into the hospital, got a course of IV antibiotics, which did cure his pneumonia. Came out, and again, he felt that he was definitely at the point where he had enough quality that he wanted to give this a try. So he went along, I think it was for about 4 to 5 months, actually in a very stable condition. But winter rolled around, and yeah, he just got a very serious lung infection again. And this time he said, I'm ready. I'm not going back into the hospital. And he died a very peaceful death at home. And we were able to keep him comfortable with the use of oxygen and medications. But that was a good example of, he changed his mind, which is just fine. And Libby's going to speak about who pays for this kind of care.
Hospice is paid for by a special, it's called the Hospice Medicare benefit. I think it was created by Bob Dole in 1982, 82 or 83. And so there's a special pot of money. When someone signs up for hospice care, you elect that benefit, and they pay for all the services that hospice provides. It's medications, visits by the hospice team, equipment, everything to keep somebody safe and comfortable wherever they live. Everything related to what's considered their terminal diagnosis is paid for by the hospice Medicare benefit. It is a generous thing. When you think about it, though, it's also saving the government money, because our patients are not being 911'd into the hospital. They're not having scans and tests and blood draws and those kinds of things. Their focus is on comfort care. So everything related to hospice is paid for by the hospice Medicare benefit. Palliative care is paid for by insurance. And so that's just like a regular not being in a hospice setting. Insurance pays for palliative care. Does that make sense? Okay.
I would also, any other things that we need to clarify as far as the outline? Yes.
You say Medicare pays for hospice, so there's a hospice medical benefit, but that wouldn't pay for the residential part if you went to a residential.
The question is, okay, Medicare pays for the hospice program, but does not pay for like a residential program, and you are correct. That's the one thing that Medicare considers, well, at least for now. This may change, but both private insurance or the Medicare hospice benefit do not pay for residential care. So it's kind of like the way we try to describe it is the patient and his or her family pays the room and board. We as the hospice team can still become involved and be involved in their care. So we follow them. Say they start at home, go to a residential hospice, and the team follows them right along. But the payment changes. And excellent observation and this actually, we've had some people say some funny things about the residential hospices range from about 350 to about 450 now? It's over 500. It keeps going up. Surprise, surprise. That is per day. And one gentleman said to us, he said, I could rent a room at the Ritz with, service that was superb and all that. I said, well, you might not get nurses for the cost of that, but and it's usually a very short-term stay. So even though it's it's a horrendous expense per day, but the average length of stay is usually about a week or 10 days. And it's wonderful care. It's in a beautiful setting. They don't look like hospital rooms. There's actually one out in Chaska called Maria Steiner. It's on a lake. It has 8 rooms. It looks like, you know, the fancy hotel. Yes.
You have to be there so many days from Medicare to pay.
Hospital.
Like the nursing
Yeah, I
home.
think his question is, you have to be in the hospital so many days
No,
before, no.
not in the hospital. In the hospital.
Say you have a 3-day requirement.
Oh, no.
That's
You
what
have
that's
to
what
get so
nursing homes
many
are.
days before Medicare kicks in.
Okay, and are you talking about if you're hospitalized and then,
Don't leave the hospital out.
oh, leave the hospital out? Okay,
Hospice.
Oh, no.
okay, with hospice, we don't, you know, we don't make the payments on, like I say, like if, say somebody is, and I hope I'm understanding your question. If someone is in their own home, apartment, independent living, then all our hospice services are paid for.
It's not tied to a hospital stay.
And it's not, that's not necessarily tied to a hospital stay.
Like home care.
When it's hospice, Medicare kicks in.
Well, it kicks in if the person signs up for hospice, it kicks in immediately. People have several papers that they must sign to allow us to give care, but then it starts immediately. There's no waiting period because the hospice Medicare benefit is a very special, separate area of Medicare. And a lot of people aren't even aware of it because, well, you know, it's been around since 1983. But again, you have to have a terminal illness, you know, not a chronic illness. And as Libby mentioned before, we just don't guess about what is a terminal illness. The doctor who must certify this, and the doctor has to put it in writing, has certain criteria that he or she goes by. The patient is losing weight, significantly losing weight. The patient is not seeking, you know, extra services or therapies or chemo, whatever it might be. So there are some definite criteria. Actually, one lady came up to me after Libby and I were giving a presentation, and she said, "Jan, you know, I love the sound of all those services, especially because you have massage. And I think, you know, I think I could use every one of the services that you talked about. You know, the nurse visiting, all that." And she said, and after all, you know, I'm 96. And I said, well, you know, you look in pretty good shape to me. And she said, and I said, well, do you have, you know, a serious or chronic illness? Oh, no. She said, I've never even been in the hospital. I said, you lucky person, you. But you do not qualify for the hospice team approach. I had to send her away. She was disappointed, but she was happy to be, you know, that healthy for that long. So a lot of times, you know, you'd love to have the services, but you're just in too good a shape, and that's good news. Any other questions? Did that clarify? It's like Libby said, it's an extremely generous program, and but you know, the bad news is, yeah, you have to have a very limited life expectancy.
You have to be terminal.
Yes.
You have to be terminal. Now, this is also something that doesn't happen very often, but in my many years as a hospice nurse, there have been people, we call them the hospice flunkies. They seem like they're appropriate for hospice care, but they don't decline like the doctor thought. And my prime example is a lady who was 102. She had nutritional problems, she had pain problems, mobility, you name it, she had problems. And she was living with her daughter, and she just kept kind of going down, down, down. And it looked like the most appropriate referral to hospice ever. And then the doctor didn't have any problem saying, oh, Gladys, we can help you. Well, first couple of months, pretty rocky. The third month, she was doing better. The fourth month, gaining weight. By the time that 6-month period came around and the doctor had to recertify her, he could not justify recertifying her. She had improved in every aspect. And so we had to discharge her, and it was such a reminder to me, don't equate advanced age to the closeness to death. Because as far as I know, she never did re-enter our hospice program, and she kept tootling along. She was very unhappy about not having her regular nurse, not having many of her medications paid for, but she just struck a different note. It doesn't happen a lot, but it's very humbling for us as a team because we realize that people do surprise us. And we had one lady in our program that was 107, and eventually we did have to discharge her because she was not declining. She had just leveled out, and she no longer fit the criteria. Any other questions? Yes.
I'm fuzzy in my mind about the difference between hospice care in an institution versus hospice care at home. What are the different expenses there?
Good question. Her question is, what is the difference between hospice care at home versus in an institution? And and again, this comes up a lot because they say, well, in an institution or a nursing home, you have 24-hour nursing care, round the clock. Why do we have to be involved? That part. Now, again, we don't cover the room and board in a nursing home setting, so that would be strictly for the patient and his or her family. But our services, or the services of the hospice team, truly are almost identical to the services that we would give in a private home or an apartment or condo. And those are covered 100% by the hospice Medicare benefit. So it's that room and board part. I mean, it'd be just like, for instance, if we serve someone in a private home, I mean, you pay your taxes and your monthly electric bill and gas bill and all that, but then we provide the nursing visits and everything. And like I say, we have a massage therapist, we have music therapy. So all those services, whether it be in an institution or at home, covered 100%. Does that answer your question? Yes.
How much would needing care be if you stayed in hospice? What's that daily charge?
The daily charge, Medicare reimburses hospice care on a daily basis, and it's about $107 per person per day.
But you're not billed.
My question was room and board.
And we do not pay room and board.
What is that?
And a room and board could vary from, I was just talking with a lady not too long ago, and she has her mom in a nursing home, and she is paying $6,000 a month. And so, and you know, I honestly don't know what the range is, but that's out of pocket. And yeah, so it's certainly not cheap, for sure. Any thoughts or questions? I would highly encourage you to read that article that is part of your handouts there, where it says Palliative Care, a Key to Living with Dignity. And I lifted this from actually the ARP magazine a few months ago. And I think this author, this Jennifer English, does an excellent job of kind of the thoughts and the goals, and that does an excellent job of outlining palliative care. And like anything else, you know, things are changing too. 10 years ago, we didn't have a palliative care team, at least in the Twin Cities. So that's kind of a much newer concept and being used now. What we talk about here today is something that you're going to find maybe not in small rural towns, but in major cities throughout the country. You can access both palliative care and hospice care. And even, you know, I mean, whether you're Florida, Arizona, Arkansas, Hawaii, there are all these programs are available. Well, I think that's everything that we have to present. And any other, you know, because like I say, there's some gray areas in there, and it, you know, you just can't draw an absolute line, like, you know, and I would encourage any of you that if you have a loved one or someone, you know, that you think fits into, you know, either the palliative care segment or perhaps hospice, you can always get a hold of, if you do stuff online. In that article, there are online places that you can go to for information. Libby is leaving her card here. You can always contact her for questions, and sometimes getting to the right person can be a little tricky. And most, you know, most physicians, I couldn't say this 15 years ago, but I think most physicians now are pretty open to having the patient or the family members bring up questions and say, you know, you think this test is really, you know, really what my dad wants? And, you know, and again, years ago, they didn't like to be questioned or challenged, but I think that's definitely changing. And there's an openness, which I think is a very good thing for all of us who are healthcare consumers. And the more you're informed, better it is. Well, thank you so much for your attention and your good questions.
Again, just like to thank Jan and Libby for presenting today. It's been a great presentation and informative even for me. So hopefully you all learned something from it. Our next Living Wise and Well will be August 4th, and it will be on digestive problems and simple solutions. So hopefully you're able to make that. So again, thank you for coming.